Hello, everybody. Hi, and thank you, Tushya and AIOS, for having me on this topic. The topic I'm going to talk about is techniques for scaffolding to prevent a nucleus drop with sutureless fixation of intraoculars. I do have financial interest with LISA, but none of it pertains to my talk today. Let's begin. Cool. I mean, the concept of scaffold is basically to support, construction workers. That was why scaffold was really constructed. But in cataract surgery, I think this word scaffold has coined a new definition for itself, where basically this is the fear that people usually have, when we're doing these nucleus drops, and when we do cataract surgery and we have these nucleus drops. This is the biggest fear: the nucleus piece might fall down. Well, let's understand what really can we do as a concept for IOL scaffold. When we talk about scaffold, the basic idea here, the fundamental to which Dr. Agarwal constructed or devised this technique is basically to pull the nucleus into the anterior chamber, place a intraocular lens below the nucleus and above the iris, and then emulsify it using a paper probe so that the pieces don't go down. And now you can replace or place that intraocular lens into the sulcus or a glued intraocular lens. Concept is basically to support the nucleus not to go down into the vitreous cavity. Well, indicating subluxated nucleus, drop nucleus, small pieces of fragments, and even IOL exchange. I'm going to take you through a few videos that would explain this procedure. I've made my 3-port pars plana vitrectomy. I have done doing my removing all the cortical matter. I also see over here that there is a very good sulcus. So I'm going to try and retain that sulcus as long as I can. And in fact, the point is, if in case it does rupture, then I have to plan for a plan B. Yes, it didn't. What I'm doing here is basically bringing this nucleus into the anterior chamber after doing a core vitrectomy and all the retina stuff and the posterior segment stuff. Now I'm placing this intraocular lens into the anterior chamber. The haptics could go directly into the sulcus or it could go on top of the iris. It depends. In this case, I have put it directly into the sulcus, so I don't really need to replace it later on. Now I'm just emulsifying it with the same paper probe that I was using to emulsify it earlier when I did have the posterior capsular rupture. And that basically pretty much ends this case. Now I must re-examine at the end, of course, the rhexis margin rims. Once that is done, I place my fibrin glue wherever required and close up this case with a well-centered intraocular lens. Let's look at glued IOL scaffold. So basically, this is a complete subluxation of the whole crystalline lens. It's going down on its way. But here, what I'm doing is measuring the white to white, ensuring that I can do a glued intraocular lens. But because my white to white was a little bit larger than 12 millimeters, I moved over to a vertical glue, and now I'm complete capsular bag with the lenses being brought up into the anterior chamber, putting some pilocarpine inside the eye. So I drop my nucleus size and this nucleus does not go down. Now I'm doing my glued IOL first so that I can actually support this whole crystalline lens along with my glued IOL and my iris. So the glued IOL and the iris support or the pupil basically are my support scaffold system here. And what I'm doing now is, because the nucleus is a very, very soft nucleus, I'm able to emulsify it with a power of probably 5. And that is what the advantage of doing this in a soft nuclei is. And that's what we have to understand. Again, I put some triamcinolone to check if there's any vitreous in the anterior chamber. There wasn't. Pupil is round and small. I placed my glue under the flaps, the conjunctiva, and that is the post-op day 1. Let's look at another case of IOL exchange and where this has really helped me in the long run. IOL exchange, basically, when I'm doing an IOL exchange, I used to do it in a different way, but now because of IOL scaffold, it really makes my life much simpler. All I'm doing is bringing this new IOL intraocular lens into the anterior chamber. Once it's in the anterior chamber, there's this fear and scare that if I use a scissor now, I'm going to touch the posterior capsule and that can have a rupture itself. So what I'm doing is I'm placing my intraocular lens, my final intraocular lens at the beginning, And now I take my scissors to kind of cut. I do use micro scissors nowadays because of the availability, and it becomes much easier. This was a rather old video, but the advantage of doing IOL scaffold with pre-placing an intraocular lens has been clearly defined in this case, and that's the take-home message which I would like to give to the audience. Very simple. You pull out the cut intraocular lenses, PC, and place and ensure that the final intraocular lens is placed directly in the bag, not in sulcus. So that's one way. The other one is where you don't have capsular support and you've done an iris claw lens where you really have to explant this lens out. And in these cases, I am here showing you a different technique of L-shaped incision. So the L-shaped incision basically helps in reducing the astigmatism, and also in intraocular lens implantation, explantation like this. It really benefits because it's one single piece of material that coming in and out. Now making my glued intraocular lens flaps and sclerotomies, I made my side port wounds. I'm doing my anterior vitrectomy through my sclerotomies. Once this is done, I'm able to now extend that L-shaped incision, ensure that I first place my glued IOL in place, because in case I unhook that, and we know that in iris claw lenses, a lot of times when you unhook, it can really just fall down. And that's why placing this glued intraocular lens beforehand has prevented a lot of IOLs from falling down as well. So this is some of the advantages of doing an IOL scaffold. So it does not just help in nuclear fragment removal, but also in intraocular lens fragments. So when you unhook this, there is a very high chance that it can slip on both your hands, or you may knock one hand to the other, and that could slip the intraocular lens from its place. And this is the advantage of basically doing a glued IOL scaffold. What are the benefits? Well, one of the most important things is you don't need a corneal wound, which is what we used to do. We used to extend the wound. You don't even need a scleral wound. All you need is a good pair of micro scissors, and you are good to go. It prevents any vitreous prolapse. So a lot of times you'll see the surging of vitreous coming up and down. And you can emulsify nuclei in the anterior chamber using a phaco probe. And also the IOL already gets its position before you have even started the removal of any nuclear frag. These are some of the big advantages of doing IOL scaffolding. I'd like to thank Tushar for having me on this topic, and I would like to also inform the audience that this is my pages that you can follow me, ask me questions, anything. Thank you so much.